Welcome everyone. My name is Boglárka and I would like to present my progress and my research topic, which is based on heart failure and heart failure device treatment. My vision is to help heart failure patients receive the most effective evidence-based therapy, and my mission is to conclude from observations which we can include in everyday clinical practice. We plan to do two studies based on heart failure and heart failure device treatment. I would like to present my first study, which is about comparing cardiac resynchronization therapy with pacemaker and with defibrillator. So we submitted our article in the European Journal of Heart Failure, but unfortunately after one month of review based on the reviewers, we had to redo the selection part because it was outdated. So until the previous year, there was a really important study which was published, so we have to redo the analysis. So we are waiting for the new results from our statistician. But I would like to introduce the study. So cardiac resynchronization therapy with or without a defibrillator is an effective therapy in selected patients with heart failure and severely reduced left ventricular function. However, the benefit of adding a defibrillator to CRT is still unclear because there have been no randomized controlled trials to compare these two treatments. So while CRT-D may further improve survival over CRT-P by reducing arrhythmic death, it does also add defibrillator-specific risks such as lead failure and inappropriate shocks, as well as costs. So we aim to evaluate the long-term benefit of adding a defibrillator to CRT and to compare CRT-D to CRT-P regarding all-cause mortality and cardiovascular mortality. So here you can see our clinical question and our PICO, and our hypothesis is that CRT-D is superior to CRT-P. We did the systematic search, and after the systematic search, we had 29 full-text articles. So let's see the results. First of all, we would like to evaluate the all-cause mortality based on the adjusted hazard ratio. So we get the number that the hazard ratio is 0.82, which means that CRT-D was superior over CRT-P. It can reduce the mortality over 18%. We also wanted to evaluate the all-cause mortality based on propensity score matching because it is the most reliable way to evaluate observational trials. And we get the results that the hazard ratio is 0.83. CRT-D was superior over CRT-P. We also performed subgroup analysis based on the etiology of heart failure. We can see that CRT-D was superior in ischemic patient, but it was not beneficial in patient with non-ischemic heart failure. And if we saw the patient above 75 years, we can see that there was no significant difference between CRT-D and CRT-P therapy in this patient population. So our strength of our analysis was that we could analyze data from almost a lot of CRT patients, and we could analyze 8 articles regarding propensity score matching, which was a prestigious data, and we could also perform subgroup analysis and based on heart failure, etiology, and ages. And our limitation was that those articles were only observational studies, and the Graz article has a huge impact on the results. But our conclusion that CRT-D is superior over CRT-P regarding all-cause mortality, and CRT-D is beneficial for ischemic patients. However, patients above 75 years could not benefit from CRT-D. So we should implant CRT-D devices, especially for ischemic patients or patients who have a higher risk for sudden cardiac death, and elderly patients cannot benefit from additional ICD. And it's essential to identify and define subgroups who can benefit from CRTD. So our second study would be also a meta-analysis. We would like to compare remote monitoring to regular in-clinic follow-up. Annual hospitalization related to heart failure in the USA and Europe are estimated to be over 1 million. Remote monitoring in heart failure patients is a good approach used by clinicians to enable earlier interventions in cases of disease progression, and however, the guideline is recommending remote monitoring at a high level, but there is no exact evidence for using it. And remote monitoring is underused in Hungary yet, but it would be reduce the burden on hospitals. So our aim was to assess whether the use of continuous remote monitoring in heart failure patients leads to reduction in all-cause mortality, heart failure hospitalization rates, and cardiovascular-related hospitalization compared to standard follow-up. So here you can see a clinical question on PICO. So we would like to compare this invasive remote monitoring system to the regular in-clinic follow-up, and our hypothesis that invasive remote monitoring is non-inferior to standard care. We performed the preliminary search, and we got 15 eligible full-text articles. So here are our results. Regarding all-cause mortality, we can't find any difference between remote monitoring system and usual follow-up. And regarding CV hospitalization and heart failure hospitalization, there was also no significant difference between the two follow-up methods. And regarding inappropriate shocks, also there was no significant statistical difference between the two therapies. So our strength that only RCTs were assessed, and we have several additional outcomes not presented in any meta-analysis before. But there are heterogeneous study cohorts and unstandardized alert actions, which is the reason we cannot prove the beneficial effects of remote monitoring. So our conclusion is, and our implication for the research, that if there is an opportunity to provide the patient home monitoring system, it can be an excellent way to enable earlier intervention in cases of disease progression. And it is essential to design and perform a study where there is a prompt and acute, adequate reaction to the system alerts to prove the beneficial effects of remote monitoring. So here you can see our specific goals. So we are on the phase of manuscript writing regarding the second project, and we are waiting for the first project statistical part, and after we would like to publish the first meta-analysis into a D1 journal, and the second also into a D1 journal. Thank you for your attention.
Yeah. Can I ask you about your first project that, I mean, first of all, that you said that one study, the GRASS study, there were some problems with this. That this is because that is too big compared to the other ones, or because that's, brought out results?
There are a lot of patients on these studies, in this study. So there was 20,000 patients in this study, so it was a huge impact because of the large number of patients.
So then you can always try to take it out. Just see what happens. So did it affect actually the outcome?
Okay, we will try. I don't know. We would not try this, but we can try. I think it was not a big problem, but we had to try to find a limitation, and it could be a limitation.
So this is not a limitation in yours. Still, if you have that many studies, and then there is one huge study, it's still worth to try this, because if there is some systematic bias on that single study, then actually that could lead to kind of worse outcome, or at least that would be good to discuss. The other thing is that also in your first study, actually the the outcome were quite wide. So I mean, in some studies, there was a very strong effect of the defibrillator, and in other studies there were not. Is there any reason for this, what you can figure out or dig out of the papers? That why do you see this?
Yeah, for example, for all-cause mortality, the patient population were different. So we, because of this, we perform subgroup analysis. So
this is the 75 years over that it doesn't really matter afterwards.
Yeah, and also the etiology of heart failure patients, so ischemic and non-ischemic patient.
Okay, thank you.
I just would like to make a short note. Don't be disappointed if your paper is rejected from European Journal of Heart Failure. It happens very frequently with almost all scientists, and in particular at that particular journal, because it's extremely difficult to publish there.
Thank you.
Just keep on trying.
We received a very positive review, so we are hopeful.
Okay.
Thank you.
Good luck.
I would like to ask you a short question about did the studies use the same criteria for deciding whether they implant a CRT-D or CRT-P in your analysis? Do you know that they use the same criteria for the decision?
No, because I know that in the guideline there is no exact criteria. There are just suggestions who are the patient who must be implanted with CRT-D and CRT-P, but mostly men's became CRT-D candidates and patients with ischemic cardiomyopathy, but in some trials there are a large number of ischemic cardiomyopathy patients with CRT-D, and in other studies there are fewer patients with ischemic cardiomyopathy. So there was large differences between the patient population. So we saw this.
And have you tried a further subgroup analysis in the group of non-ischemic patients? So was it, for example, ejection fraction dependent, the benefit or the lack of the benefit?
We can use just the hazard ratios, and these hazard ratios were published in the articles. So we could do this based on the hazard ratios. So there was no hazard ratio regarding the ejection fractions, unfortunately.
Okay. Thank you very much.